Welcome back to Oncology Update. My name is John Marshall here from Georgetown University, Washington, D.C., the land of freedom. I don't know what it is the land of anymore, but welcome back to episode 3 of Oncology Update. Our theme for this session is going to be, how do you stay up to date? How do your patients stay up to date with all that's going on in the world of oncology? And are you in fact delivering state-of-the-art treatment? Or are you in fact maybe delivering some recommendation that maybe AI created? So we do want to be careful about that. But before we do, let's kind of start with some of the news of the week. Everyone knows who Dennis Slayman is, an amazing scientist and clinician who his group really defined the whole HER2 targeted pathway, defined the use for trastuzumab in more than one disease, and turned HER2 into something that you didn't want to now something it is you want, certainly in breast cancer. And if he, of course, rightfully receives another major award from the National Foundation for Cancer Research. So a big shout out to Dennis Slayman for the incredible progress that he has made and the impact he's had on so many people. You think about how many lives that man and that science has saved just through that research that he's done. It really is impactful. On the other side, I want to give acknowledgement to a Dr. Harpreet Singh, who worked at the FDA in drug approvals, right? So the whole idea of giving back to the government, working for not very much money to try and establish the metrics, et cetera, for FDA approval for medicines. But just recently, Dr. Singh took a job as the CMO for Precision for Medicine, which is basically a research CRO. And that's very much similar to what we see here in Washington, of that kind of revolving door between working for the government and then working for industry, taking the skills and the inside knowledge and the like that's important out to the rest of the world to try and improve the process there. So that's a little bit what's going on in the world of drug development. But maybe most importantly, this is Juneteenth, actually, that we are recording session 3 here, episode 3 here. And it's also part of Pride Month. And so we have a lot of folks who are out there who really are underrepresented in our research, underrepresented for access to the treatments we have, for a variety of reasons, not just here in the United States, but everywhere around the world. And I know many of us are working to try and level that playing field. I always think about this as a really difficult subject. Is healthcare a right or is it a privilege? And we try to dance both of those here in the United States with sort of private health insurance and other government health insurances underneath that, clearly not providing the same level of care. And at these kinds of months that we think about those who are less fortunate or those who have struggled with their own personal world in a world that's not necessarily built or ready to receive them. And so I do think we have to make sure we're taking care of everyone and acknowledging all of that goes on. So it's an important month, the month of June, for us all to stop and reflect a bit on all of this, particularly in healthcare. But let's look at the science of the week. Now, you're going to think you're waiting for a Nature paper or some major JCO paper. I'm going to actually show you a minor JCO paper. It's written by a very good friend and a person who I really go to for my sort of ethics checks. And this is Dr. Paul Helft out in Indiana. And his team put forward a survey paper that was published in JCO looking at what patients are doing on the internet, what they're going to see on the internet, and then what they're bringing in to us as information they have found on the internet. Again, sometimes it's supportive care things, but often it's therapies that someone has posted somewhere on the internet that might be helpful for their cancer. They're looking for a better answer than the ones we are giving them. And comes to mind is how many times a week does somebody come in with, I've heard that ivermectin can really help cure my cancer. Or, if we just allowed more medical marijuana, this would solve the whole problem. People wouldn't have cancer. Maybe they wouldn't care about having cancer, but they wouldn't have cancer is what they think. Or turmeric is my favorite one. You would think that whole, populations would never get cancer because of the turmeric that is in the diet in certain populations. But no, that seems to be a popular one. Acupuncture and other sort of mind-body approaches are, of course, very popular. But many times, we in the healthcare industry aren't really qualified to comment on the things that are being brought in, or they irritate us, or they just take time, and we spend time then waving off the things that patients have found on the internet. And there's this entire, burgeoning literature around this. And we clearly see that social media and the internet are actually promoting this sort of alternative oncology all the way to what we would call quackery. And the publishers want this. In my position in academia, it's very common that I'll get emails from some new journal that's just coming out that they need new reviewers, or they want an editorial board or something. And I see that mostly as spam email myself, but somebody's saying yes to that, and somebody then is publishing stuff that may not be up to the same scientific rigor that we're used to. And we might come across some of those things on the internet searches and not really be able to judge what it is we're seeing. And this has created this so-called predatory journals that are out there to just make a living having medical information in them, no matter what quality of medical information is out there. And a nice recent paper did summarize a lot of this that's out there, to be careful, because when we're going online ourselves, we really need to figure this out. Now, where do you go for your information to stay most up to date? Well, I bet you go to Up to Date sometimes, and that's obviously a much fuller annotated version of things. It requires you to do some reading and thinking in order to apply the knowledge there. But most of us are going to NCCN. Used to be that, around here at least, that we would not allow our fellows to cite NCCN as the reason to do a treatment, right? That was not the source document. The source document was the study on which the NCCN guidelines were based. So you had to know where the NCCN guidelines came from so that you could interpret that. But somewhere along the way, we sort of slipped off of that, don't you think? Is that if it's on there, then it's legit. And the payer on the other side is like, well, if it's on there at the right level of evidence, we'll cover it. So it's almost more important to be on NCCN than it is on FDA. Once you're on the market, NCCN will get you covered. So it creates a sort of new target that's separate from the FDA, different levels of evidence. But did you look down in 6th point at the very bottom of the NCCN guidelines on every one? It has the disclaimer, and I'm going to read it just so you guys can hear this out. So NCCN explicitly disclaims the appropriateness or applicability of the NCCN content, the guidelines, and any derivative resources, or the use of or application of the NCCN content, the guidelines, or any such derivative resources to any specific patient's care or treatment. That's exactly how we use it, right? We look up a patient who, we're not quite sure what the rules are. We're not quite sure if that drug's got approval or covered. We're not quite sure what to do next. So we open up NCCN and make an individual patient decision based on what's on that, even though they, in fact, say that that's not what we built it for in the baseline. So I just want us to remember that that's where that sits. Now, in the old days, I used to be able to know pretty much everything I needed to know to be a practicing oncologist. I could study it, I could remember it. Nowadays, I can't. And there's so many new drugs. They have so many new names and funky names that I can't remember, that in fact, I'm constantly, even in my own space in GI cancer, needing to reconfirm or look back up in the internet of some place, NCCN, Up to Date, or even just Google, to figure out where the answer in fact is. And so I just did a little looking myself about new drugs that were approved but now have been withdrawn. It came through my inbox that a drug, infigratinib, which you may know as a FGFR fusion molecule for cholangiocarcinoma, was withdrawn. The approval was withdrawn, originally approved in 21, just in May 2024 was withdrawn. And so if I had one of those FGFR fusions, even though this drug's on the market, I can't use it for cholangiocarcinoma. But if I looked that up and I didn't see that it was withdrawn, I might not. I may only see the FDA, the positive FDA approval. But there are a bunch of them here. And in fact, there were 29 drugs withdrawn that had initial approvals within cancer medicine. Some of the others that we noticed was Blenrep. Okay, so Blenrep's a drug for multiple myeloma. It's been withdrawn. It was withdrawn in back in 23, but new data, we think it may be coming back on. So it depends on when you looked up what your reference pops up in your search of whether that drug's in or whether that drug is out. In my world, Keytruda, pembrolizumab, was originally approved for gastric GE junction cancers, but now that's been withdrawn depending on what your PD-L1 status is, et cetera. And then also a really interesting one that maybe, you younger people don't even know the arc of, but Mylotarg was originally approved in 2000, withdrawn in 2011, but then back on the market in 2017. So you get my idea of what really is out there, what really is FDA approved. And these accelerated approvals give us access to medicines, importantly, but then sometimes they are pulled back. Now, just in June, there were a bunch of approvals, 6 new approvals. I want to read you a couple of them because they're pretty pedantic, if you will. One of them is a drug called blinatumomab. You've probably heard of that one. But the approval is for adult and pediatric patients 1 month and older, CD19 positive, Philadelphia chromosome negative, B-cell precursor ALL, a very specific subset for that patient. How about this one? Repotrectinib. We all know about this one, but this is for 12 years and older for patients who have NTRK gene fusions. Now, I've only found one of those in my entire career, but you need to know that there are drugs that just got added to the list of other drugs that are out there. Another one is a drug called Breyanzi. I believe it's how you pronounce that. And this one is for adult patients with relapsed and refractory mantle cell lymphoma who have received at least 2 prior lines of systemic therapy, including a BTKI drug. So you got to really know what's going on. If you're a general oncologist, how would you know what's going on? So you're dependent on looking stuff up. You're dependent on our education resources and other online resources to keep up. So how about this one? This is real or not real. This is a paper that a search found, and it's for entrectinib. You remember I talked about repotrectinib. This is for entrectinib, for NTRK fusion positive solid tumors after larotrectinib or repotrectinib. So a third line, if you will, for entrectinib. Now, this paper is from the Journal of Clinical Oncology, says it was published in 2021. And in fact, one of the authors is one of my partners here at Georgetown, a guy named Mike Atkins. Rick Pazdur is listed as an author on this paper. Michael Slayman, Jeff Weber, a lot of prominent people are authors on this paper. And you would think if this came up in your inbox that this is real, right? And so you might even take this paper and send it to the insurance company, to the guy at Aetna, and say, look, I got a JCO paper here that says I got a response rate that's very high in this patient population. It's already an approved drug. Let me give it to my patient in front of me. Except it's not real. This paper was created by an AI search engine, and it's a JCO paper. It was completely the right format, the right color scheme, the right font, the right references. But what made us all suspicious was the author list. Why would Rick Pazdur from the FDA be on a paper such as this? Mike Atkins doesn't do this kind of research technically. And then we went one further step, and in fact showed that the page numbers from this JCO paper didn't line up correctly with the journal. And so this really suggested that we were getting a bum paper. This was a made up, what they call hallucinated paper. So we also have to be careful at that level. All right. So how do you keep up? And I want to kind of shift gears a little bit to our maintenance of certification, or MOC. Now, I'm in internal medicine. I was originally boarded in medicine, then oncology, and I've only maintained my oncology after a while. It's my fourth go round. And this fourth go round, because I have to do it every 10 years, this go round, I decided not to sit for the exam and to take the maintenance of certification questions. Those of you who are doing this out there know what this is all about, but maybe some of you do, some of you don't. So every quarter, I get 30 questions in a portal. And these questions are HEMONC questions, ONC questions, med-onc questions. And the way I do it is I put 2 hours on my calendar each quarter. 1 hour, I do 15 questions. Next hour, I do another 15 questions, just so I make sure and get it done. But you also know that when you go on to this, you have 4 minutes to answer the question, and there's a clock running up in the corner there. And you can use any online resource that you want, but you can't talk to somebody. So when I originally started this, I thought, division chief, we got a big fellowship program here. Maybe I should do this in front of the fellows. And they're like, nope, you can't do that, because this has to be just you and whatever internet resources you have. So they're giving us the internet to do this. So what I do is I have 2 screens. I put the question over here, my little clock running over there, and open here, I've got, what do I have open? I have NCCN guidelines, and I have UpToDate open on my computer screen. And I read the question. It's always a leukemia question or one more breast question and the like. And I don't know a lot about that. So I really need to understand what my answers are. So I look it up, and I'm doing pretty well. Every 30 questions, I might miss 3 or 4, but that's with all of these resources. And I get nervous about the clock running down, and I am pressed for time. And so in the end, I just hit 1 and say, I hope I'm right. And most of the time so far, I'm right, except the GI questions. I'm getting killed on the GI questions because I really know the medical literature in GI cancers. And one of them recently was a case where a patient had liver mets that was resected, had not had adjuvant therapy a couple of years before. And there's no literature on what to do with that patient, none at all. And so I put, you observe the patient, which is to me what would be the standard of care. If they had isolated liver met, it was removed, you don't know what to do. But then I missed the question, missed it, because it said I should give chemotherapy. There's no data for this. In fact, the data does suggest maybe progression-free, but no overall survival benefit, no true adjuvant effect. So I go on to their reference, which was the NCCN guidelines. And down in the small print, some branch point way down here, it basically said, look, if you've never given adjuvant, consider giving adjuvant. That was the correct answer by the ABIM version of the process, which in my opinion is a very controversial answer. And yeah, I could see the argument for, but there's no literature to support that. And so, this is what I'm kind of frustrated. Now I'm getting nervous every time there's a GI question that comes up because, do I know too much? Do I not know enough? What's going on here? Why am I missing the GI question? So it is clear that we can't know everything anymore. There's too much coming at us. There's too many funky words. There's too many subtleties to genetics and the drugs, etc. So we need to get better. I need to get better at online access. I need to have trusted sources. Sure, UpToDate and NCCN are very good sources. Don't hear anything different than that. But we also need to have that sort of inside baseball knowledge about what the right way to do it is, what's the right way to dose things, this sort of thing, right? So we need good over our shoulder help that the internet can provide to make sure that we're providing state-of-the-art care for the patient in front of us with all of its complexities and all of its changing that's going on, so that we're dependent on it just as much as everybody else is. So we need to get better at it. And so with this, I just challenge all of us to think a second time when you're going on a search and you find a paper that supports what you want to do for a patient, do some cross-referencing. Think a second. Was it created? Real? Is it on guidelines? Is it cross-referenced with other sources before you then go forward? And if it's a therapy you've never given before, try and find somebody who has and talk to them about what is the right dose, what is the right way to monitor for side effects, et cetera. Because those kinds of subtleties are awfully hard to get off of the internet. And phone a friend and figure out, because I think with that, we'll all be better doctors. And using this great tool, this great knowledge base that's in front of us, using it wiser for the patient. So to really try and dig down deeper on this issue of the ABIM and MOCs, there's a lot of confusion about that. We are lucky enough to have a guest visit us for a brief interview from the inside, one of the leaders at the ABIM. So as promised, I have a world's expert on how we get board certified in oncology, and is lucky enough that Dr. Suresh Nair has agreed to spend a little bit of time with us. Now, if you don't know who he is, you should. He's an important guy. He was the physician-in-chief at the Lehigh Valley Health Network in Pennsylvania, just north of where I'm sitting. When I looked through his resume, the guy likes Pennsylvania for sure. He's been from the east side to the west side with all of his training, and has trained in some of the best places in the world. And he has dedicated himself to building just an incredible practice there. Part of his busy life as well has been to be involved in the ABIM, the process and certifying us all for our licensure. And he's an oncologist. And in 2022, if my numbers are right, he actually took on the leadership role in the ABIM structure over medical oncology. And having somebody like that to give us a few minutes is really special. So Suresh, let me first say thank you and welcome.
John, I feel honored. Thank you so much. And to be, as I said, being with the legendary oncologists who I respect highly. Thank you.
Well, I get in trouble a lot, as you know, so hopefully we'll keep each other out of trouble on this one, because for the first time, this was number 4 for me on going around on getting recertified, and I thought I had been doing it right. But it was December 15th of 2023 that I realized that I wasn't doing it right. My CMEs weren't MOCs, for example. And so I had to very quickly figure out how I was going to do everything by the deadline so that I maintain my board certification. So I had a panic moment here as a senior doc. I wanted to talk a little bit about my choice, for example, to take the test, sitting down, formerly number 2 pencils, no longer, versus the quarterly tests as a way to maintain. And just to get your high level, that those of us in oncology are doing this, who's doing what, or everybody, it's a gamish all over the place.
I've been on the ABIM MedOnc board for the last 5 years. And as you said, the last 2 years as the chair. So I was there as the board responded to diplomats that sometimes the 10-year exam took time out of practice to go to courses, and it was very stressful. And especially in a field like oncology where things are changing, by the week, by the day, some of the questions, I know you probably had the same experience. In the areas that I spent a lot of time in, like melanoma, kidney, I was getting some of the questions wrong because the test questions were written 5 years ago, and they have to go through verification and standardization and all of that. So the longitudinal knowledge assessment was launched. We have about almost 14,000 board certified oncologists. 85% of them are engaged in the LKA once they become eligible for it.
Wow.
And about 15% are choosing to do the 10-year. I also did the 10-year exam about 2 years ago. I've decided to do the 10-year in oncology, and I'm doing the LK in hematology and in internal medicine. I don't practice much hematology anymore, but I was originally boarded in that at University of Pittsburgh. I thought I would try it out, and it's been a bit humbling, but I have a barely passing score and continue to improve in that. We are finding that we're continuing to listen to the diplomats, and we're looking at making some changes, because I too, the week of Christmas into New Year's, was reading a lot of up-to-date to get my mock credits, because I too had a deficit, and I didn't have the 100 that was needed. And so at the board level, we're looking at there is credit for the LKA. You do get mock credits for that, which I think more and more a lot of diplomats are going to. But we're working with ASCO, working with thought leaders into all facets of CME and maintenance of certification credits.
Yeah, no, I think that's really great. And you're having to live it yourself. You know what it feels like when all of us are out there, because you and I are pretty specialized. A lot of generalists might do better on some things, but still need the props, resources and source things to help with the questions. When I first started, I did really badly on the first 30. I have to share with you that at the 4 minutes was stressful to me. I kept watching. I wasn't very good actually at looking things up. And as I've done this now for a year or more, I actually realized that I've gotten better at looking things up. Now, what I'm not sure of is that making me a better doctor or not? I mean, I can find the answer, what's being asked, but I don't necessarily have any familiarity with what I'm talking about. So I can match the words up to get the right answer. But how much feedback have you had in that way that people, because I do feel smarter. Actually, I used to dread the time when I was doing the questions to now sort of looking forward to it because I do leave knowing more than I did before. What's been the feedback so far to you at your level?
The feedback's been very similar to you, John, in that the 4 minutes is stressful. There is a time bank that you can click on for extra time for certain questions. I too, on the hematology, which I don't practice as much, and I'm doing it for pure learning, I didn't do that well in the first two, and now I've been engaged in about 2 years and keep getting better. One of the things it's made me do is areas that I feel weak in. I do when I have some time read up on that area a little bit, and I'm noticing my scores going up and getting expertise. We are, kind of wrestling with certification versus education. So it's not a pure education tool. When we go to ASCO and we sit at the education sessions, that's a pure education tool. This is also a summative assessment. And there's a lot of science at ABM. I've been very impressed with the test gurus there. There's a lot of science that basically about 96% of us end up being certified, but it is stressful to some degree. But I think all of us believe in lifelong learning, and there is some science that when the test has some stakes, we actually learn at a higher pace.
Yeah. No question, my juices go up on when I'm doing those questions. No, I totally they do, and I believe I take away things that I wouldn't normally have ever learned if I hadn't come across the question. Let me come back to the, you miss questions, I miss questions, but in our own field, right? So I'm getting the leukemia questions right, but there was a question the other day where it was a resection of a colon met in the liver. And the question was, do you give chemo afterwards? Well, I happen to know there is zero literature to tell you what to do one way or the other. And when I got the answer wrong, because I said to observe the patient, and then in the subtext the reference was NCCN guidelines. So I went to the NCCN guidelines and saw that said, well, consider this. And so, of course, you know too much, right? And so it's a frustrating moment. How do I miss that question when I know the literature there? And you and I talked a little bit before about how does the ABIM keep up to date? Where are the sources of the questions, that sort of thing?
So we have test writing committee and a test approval committee, and our board has given feedback. For instance, in the LKA, there's 30 questions. There's usually at least one or two that the standard of care has changed. Even if the question was written, 2 years ago. I think a clear case would be in melanoma at the plenary. The neoadjuvant changed from Pembro to, Ipi-Nivo now, the 2 doses. And we have there's been test questions that if you do what we heard at ASCO, what's in the New England Journal, you probably could get it wrong. So one of the suggestions at our last board meeting was to have a group of experts, literally the week of go live of LKA, go through with it with a fine tooth comb, because it is very frustrating to diplomats. And
But I was thinking too, in my head was like, could you put the date up there? Because I remember we were talking about, if I go on a Google search for something, and if I find an answer I like, but it's an older answer, it might not still be correct, but it's the one I
exactly.
was looking for.
Hmm.
And so I don't keep looking. I'm done. I validated what I thought I knew, and then I move on. And so, as you say, this is assessing a moving target. So there is a time, but I think your strategy is perfect. It's just making sure that folks have a good look. That still wouldn't have solved my problem because
No, and
my
I
problem
think,
was,
and
yeah.
we acknowledge that there's just some bad questions. That question, you were right, based on the literature, based on studies, and NCCN sometimes is just more opinion rather than studies. And so unfortunately there are in the board, so they are continuing to look for more test writers. We are starting to get a good number of applicants. And then one other important direction that the board is going in, based on listening to the ASCO survey of the diplomats, is to tailor the exam so that 70% of the exam will be general content, but
Hmm.
30%, we can't hit every narrow specialty, but the major specialties that we have, that physicians in the future could say, I specialize in GI or I specialize in lung. And so it can be more tailored to them.
Yeah.
Because this is a summative assessment and the science has to be intact. Right now, we're working on what's called practice profiles and kind of focused assessment. And we'll be having the fall meeting where our committee will present a lot of stuff to us. So I think we have Furman McDonald as the new CEO and president of ABIM. Had a distinguished career at Mayo Clinic, was at Penn, and really is a strong listener. And I heard his vision at the ABIM Council last week. There was always this feeling the board was a bit tone deaf to the diplomats, and I see that changing. I'm a practicing community oncologist who has been lucky enough to have partnerships and stay involved in NCI trials. I'm supposed to be 40% clinical, but I end up being 80% clinical in my 40% time. So I hope I bring the practicing physician perspective to the board. The board has been receptive, and sometimes it does seem like it's turning a plane around because they have to keep the science and the validity that the board certification means, that
Yeah.
it needs something to the public. One of the things we want to do is to celebrate maintenance of certification, but continue to evolve. And one of the areas we're grappling with now is the quick adoption of AI. Now with Siri soon going to have AI on our phones. Pretty much any Google search, there's an AI running in the background. We know we can't run away from societal innovation, so we just need to continue to see, what's the most important things to try to test. And more, we're actually finding it goes back to John, how you started. I think trust and being able to trust your physician, because patients are going to be confused. There's going to be misinformation. There's going to be a lot of things. So how do we test for trust and the things that makes a human physician different from a robot?
Totally right. I'll be quick, but the AI thing you mentioned, there was some complicated gene in one of the questions, and instead of typing it, I tried to swipe and copy it, and this alarm went off, and it basically says, if you do that one more time, we're going to do something bad to you. So I haven't done it again. But anyway, so you have put some checks and balances on the ability to just cut and paste that question over and put it in AI and see what the answer is. But listen, I know you've had a busy day already, and you're giving us extra time on short notice to talk about a really important question about how do we keep up to speed. And you are the sort of overseer of truth in many ways. And like I am proud of my certification and I am proud to be part of that club. We all worked very hard to get the first one. And so we should continue to maintain that. And I think it's great to hear how both receptive you are, but at the same time, holding our feet to the fire to make sure that we're providing the public with a trusted human on the other side who knows what they're talking about and knows when they don't know what they're talking about, maybe more importantly, and knows how to figure it out for the patient in front of us. So Suresh, thank you so much for this and good
Uh,
luck as you continue in your leadership role.
John, I really appreciate it. Thank
Very
you so
good.
much.
All right. Thank you.
Okay.
Thank you all for joining us for episode 3 of Oncology Update, where we focused on the whole concept of how do we stay up to date. I'll see you in a couple of weeks for episode 4.